Hello, I'm Susan Cole.
And I'm Matthew Hodson.
And welcome to aidsmapCHAT, our show bringing you news for people living with HIV all around the globe.
We have another excellent lineup of guests for you today. We have Andy Seale of the World Health Organization, Dr. Mike Brady, who's the LGBT health advisor to the UK government, and Jacquelyne Alesi, who's a global community leader spreading the word about U equals U, undetectable means untransmittable.
What fantastic guests we have this week. I'm very excited.
Me too.
But talking about being very excited, many people may know that it's for us in Britain. Some of us have been celebrating the Queen's Jubilee.
The Platinum Jubilee.
Platinum, one of her jubilees. I've lived through so many. But there I was watching the TV like so many of us in the country, and lo and behold, there was Matthew waving the biggest flag I've ever seen in all my life. Would you like to tell everyone about that, Matthew?
Well, I was asked to do it. I think one of the things which I always bang on about is how the lives of LGBTQ plus people, lesbians, gays, bisexuals, transgender, queer people, are often erased from the historic record. And so when I was given an opportunity to be part of this event, which is about history and it's about celebrating the last 7 decades, I thought I couldn't really turn it down. So I wanted to be there and to be kind of out and proud and to say that LGBTQ people have always been a part of the fabric, not only of the UK, but also of the world. And also I wanted to really celebrate lesbian, gay, queer activists and the history of HIV activism as well. So I wore this T-shirt, very classic design. And yeah, I had friends call me up from Australia and from the United States and from the Bahamas saying that they saw me wearing that T-shirt on television. And obviously all of Elizabeth's reign, so all of the HIV has been within Elizabeth's reign. So, that's 36 million people have died during her reign of HIV-related illness. 37 million people now are living with HIV. So I think it's really important that we recognize that these are the voices, these are the faces which perhaps aren't always seen to be a part of that pageantry. And I really wanted to be there to represent all of us,
Lovely.
It was fun.
Do we bring our guests on?
Enough about that. Let's bring our guests on. So our first guest is the wonderful Andy Seale from the World Health Organization. Hi, Andy. How are you?
Hi, Matthew. Hi, Susan. Good to see you both. Congratulations on representing queerness at the pageantry. Fantastic.
I represent queerness wherever I go, but sometimes I do it on TV as well. Now, talking of queerness, one of the things which I'm really keen to talk with you about, because I get asked about this a lot, is monkeypox. Mm-hmm. So what are the case numbers like right now?
So I think as of yesterday, which I think was the last update, we're talking about 780 confirmed cases. So that means they've been confirmed through laboratory testing. And these are cases that are outside of the endemic countries. So monkeypox is endemic in a number of African countries. And there have been a number of cases actually this year. They're not included in that number that I just shared with you because this is an untypical outbreak. This is an unusual outbreak that's predominantly across Europe, but also across a number of other countries around the world. But I think the UK, Spain, Portugal in particular, Canada and the US are seeing significant numbers.
And are we expecting to see these numbers continue to rise at the same rate, or do you think that they may plateau?
That's the golden question. We think we will see cases rise, as with any disease. As soon as people become aware of it, including healthcare workers, we see more cases being detected, more people coming forward to ask about unusual symptoms. They're now learning more about the rashes, about how monkeypox manifests itself. And we do believe that, it may have been around for some time, but perhaps the symptoms had been mistaken for STIs, for example. And so now we're really much more focused around really doing some positive case identification through testing, and then really working out the context of where transmission may have occurred. And I'm sure everybody watching this will be aware that it is disproportionately affecting gay, bisexual, and other men who have sex with men. And so it's in that context that we're really trying to explore and learn as we go with communities.
And how do we create? I mean, how do we ensure that we reach people who are most likely to be affected, which is gay and bisexual men and other men who have sex with men? But how do we do that without stigmatizing them?
It's really hard. It's really about getting the balance right, about calibrating the message. I think in the UK, you've had some fantastic advice from people like Matthew at Public Health England and others. Susan joined a community call with us a couple of weeks ago. We're going to be reconvening community groups this week. I think that's the trick. It's, when people working in bureaucracies like myself, whether it's at national level or internationally, we need to have that kind of opportunity to test out approaches, messages with communities who are affected, because clearly we need that targeted messaging to reach people so they can protect themselves and so they can take action should they fear that they may have become in contact with monkeypox. But at the same time, we don't want that to spill out into broader populations who are already potentially prone to homophobia and all of the all you said before we could swear. I'm not going to swear. All of the BS that came with HIV, the stigma, the discrimination, the nonsense really that really blighted, particularly those early decades of HIV. We've learned through HIV, and I think really building on that learning with HIV NGOs and related NGOs and community groups, I think will be particularly critical moving forward.
No, absolutely. And if we could move to HIV for a moment. I know you've worked in HIV for many, many years, Andy, but the WHO have recently released a new HIV strategy. So what's actually new this time?
Right. So thanks for asking the question. So we spent a couple of years developing a new series of strategies to take us from 2022 to 2030, covering HIV, viral hepatitis, and sexually transmitted infections. So essentially, at WHO, we need a World Health Assembly decision in order for us to continue with our mandate. So we do link to the strategies in UNAIDS and others, but we need to go through this process ourselves. And clearly, we're in the SDG umbrella environment, so we wanted to make sure that we've got a strategic framework that really helps steer the health sector response, which is complementary, obviously, to all of the other responses around rights and community engagement, etc. So what's new? You'll see a stronger focus on integration, a stronger focus on community engagement. You'll see a really strong focus on innovation. For the first time, we've started to talk with some confidence about a potential HIV vaccine, for example. We've not done that in previous strategies. Looking at the timeline as well, we've got a slightly longer timeline to 2030 than normal strategies that might be 5 years. And so I'm very excited about what we've got in this framework. It also allows countries to really identify the actions that best suit their context. So it's not, it's not a prescriptive document. It's a fun document to navigate around. It's a modular document, and you can really choose those actions that cut across STIs and HIV, or just focus in on harm reduction, for example, if that's your thing.
Do you really think we're going to have a vaccine available before 2030?
I think we're going to see progress in that field. I doubt that we will see, mass kind of like vaccination programs within that framework. But I think we will see some exciting developments that build on the back of long-acting innovations that we've seen as well, learn from the technologies there, potentially harnessing some of the work around mRNA vaccines that, of course, were so critical to the COVID response. So I think we have to be hopeful. So again, it's balance. Once again, it's about providing a strategic framework that continues to inspire investment in innovation, but obviously not creating an unrealistic picture. But I think we will definitely see progress, definitely.
Great. Well, thank you so much for coming on and joining us today.
Pleasure. Thanks so much.
Our next guest we're going to go straight into it, is Dr. Mike Brady. He is the LGBT health advisor to the UK government and also the medical director of Terence Higgins Trust. Is that correct? Is that your correct title?
That is my correct title. I'm also an HIV and sexual health consultant. Fingers in too many pies, some people might suggest.
So many hats you have, Michael. More than the Queen. Michael, we have very ambitious targets to get to 0 HIV infections by 2030. But what actually needs to be done to ensure people who have dropped out of HIV care have re-engaged with care to actually reach those targets?
I think that's a really important question, actually, because we all across the globe are fighting to end this epidemic. And as you say, we've got a very challenging, but I think achievable target within the UK to end HIV transmissions by 2030. And there's a number of different areas of focus to achieve that. We're very used to talking about testing. We're very used to talking about that first pillar of the care continuum, reducing the proportion of people who are living with undiagnosed HIV and thinking about better testing strategies, using new testing technologies, reaching those communities who are not naturally testing. And we've seen great success across the globe, and also particularly in the UK, where over 95% of people living with HIV are diagnosed. But as you say, there's other pillars in that continuum, and one area that I think it's important that we have an even greater focus on are those who are diagnosed, so aware of their HIV, have perhaps engaged with care at some point and are disengaged from care now. And it looks like that may be somewhere between 10 and 20% of people living with HIV. So in a way, particularly as we get better with testing, it's becoming a bigger problem than the undiagnosed, certainly in terms of pure numbers. And we've colleagues of mine in South London, actually, at 3 hospitals in South London, King's, Guy's and Thomas's and Lewisham, have been running a project over recent years funded by the Elton John AIDS Foundation, particularly focused at this group, and have managed to engage just over about 20% of about 800. We think we have about 800 patients across those 3 hospitals who have disengaged in recent years. And they are people who are disproportionately living in poverty or in lower deprivation areas, disproportionately women, and disproportionately from Black African communities. And they are at risk themselves of getting ill. They're at risk of unknowingly or unwittingly or unnecessarily transmitting the virus because they're not accessing or able to access treatment. So I think we need a real shift of our focus to these communities and a real investment in the same way that we've seen investments in testing, in engagement in care. And it's a lot of effort. Certainly colleagues of mine would say that, those that have been working on that project. It's mostly manpower. It's mostly having people to do the legwork, to make the calls, to engage, to connect with people, to give them the confidence to come back to care. But it's also work that happens in other areas. It's really about getting into those communities, giving these people who clearly, for whatever reason, don't have the time, don't have the trust, don't have the confidence in our services, the ability to re-engage. So that really strong community partnership and working at grassroots with the people who are most affected is really important as well.
And what do you think are driving the health inequalities affecting people of colour living with HIV?
I think it's things that we see in other areas of HIV. I think some of them are similar reasons why people don't necessarily test, why people don't necessarily always or sometimes struggle to adhere with their medications. There's structural racism, which impacts on health-seeking behaviour and general health. Interestingly, from our study, we also saw that when asked for why people had disengaged or weren't able to come, often there were competing priorities. So people living in poverty, people for whom putting food on the table or heat in the room or dealing with their asylum application or looking after their kids is much more important than managing their own health. So there are societal and economical and structural things that we need to do, as well as addressing stigma. That's another thing that really drives people from engaging in care, as we see it as preventing people from testing as well.
Yeah, I always say that when we tackle stigma, it's just absolutely crucial to ending the HIV epidemic, because it is barriers to testing, it's barriers to accessing treatment, and what we're talking about, disengagement in care. Stigma is affecting all of these issues. I want to talk with you about your role as the LGBT health advisor to the government. I mean, you know, an incredibly challenging, incredibly important role. What do you consider to be the major achievements you've had so far?
It is a challenging role, I would say, but I think we have made some achievements. It's probably worth putting it in the context that, you know, there's myself and a very small team, so I need to give a shout out to Lizzie and Tash in my team, and I only do the role part-time, as we've said, and a lot of it is much more about sort of influencing and advising others to step up their game in terms of addressing LGBT plus health inequalities. I don't have a massive budget, so I can't fund a lot of stuff myself. So a lot of it is really about advising, supporting and encouraging others to do better, because we see health inequalities for LGBT plus people pretty much across the board, whether we look at outcomes, access to care or experience to care. So I would say that there's a couple of projects that I would say I'm particularly proud of. So some of our work is really about working across the board, addressing all LGBT plus health inequalities, and some are working in very specific areas for specific groups and communities, or in specific clinical areas. If I could just briefly give you two examples. The first is the Rainbow Badge Project, which we took over the funding of at NHS England, an amazing project that was set up by a great clinician, Mike Farquhar at Guy's St Thomas's, where people pledge, so they wear a badge, pledge to be better able to address LGBT plus health inequalities. And we've now funded an expansion of that project that now is working with nearly 50% of hospital trusts across the country, supporting them in the widest possible way to have better training for their staff, to have better data collection and monitoring around LGBT plus patients and staff, so they can better understand their experience, as well as looking at their policies and procedures, making sure they're inclusive, and sort of building up from the bottom up, if you like.
But I mean, you know, I think the rainbow lanyard thing, which is absolutely great, and I you know, had people say, you know, oh, it's really wonderful when you see someone wearing a rainbow lanyard, you're thinking I'm safe. And I think perhaps particularly for communities where, you know, perhaps being gay or being lesbian is a real challenge, or for trans communities who, you know, obviously can often feel very discriminated against in the provision of services. But then it got a bit confused because people started adopting the rainbow for the NHS during COVID. How are you making that distinction? How are you kind of reclaiming it? Or are you using a different symbol?
Yeah, no, you're right. I mean, I think the Rainbow Badge project itself, I think, has a really powerful brand. So we're not changing the name, and I completely agree that the rainbow has increasingly been used as a thank you for NHS staff during COVID. So we are using the Progress Pride flag for a couple of reasons. It's more inclusive because it has extra colours for trans and non-binary communities and for LGBT plus people of colour, and it separates ourselves. So, you know, we're keeping that very strong connection with the rainbow, which in itself is such a powerful symbol of the LGBT plus community, evolving it to be more inclusive, and in that way, kind of separating it from rainbows that might be used for other reasons at the NHS.
Right. And what are you, do you have a role to play in the current kind of discussion around conversion therapy? Because that's been quite controversial.
It has indeed. I don't have a specific role as such. You know, that's very much a government decision. And although you did introduce me as the government advisor, my role was set up by government. I'm actually fully employed by NHS England now, although I do advise the government. NHS England is a signatory of the MOU against conversion therapy, and I'm proud that our organisation has signed up to that. You know, calling for a ban for conversion therapy for all communities in all settings, alongside a wide range of other organisations. But my direct involvement, certainly in political decisions around that, is very limited, if anything at all.
Right. Okay. Mike, it's been fabulous having you on the show. Thank you so much for joining us.
Thank you, Michael, and hugs to your dogs, who I heard barking in the background for a bit.
I was going to accuse you of that, and then I thought, oh, maybe it's Susan's dogs.
No, I've locked my dogs away.
Apologies.
I have to admit, my cat actually came in whilst we were broadcasting. I was like, please don't jump on the desk. Thank you, Mike.
Thank you very much, Michael. Bye.
So, at the Queen's Jubilee pageant, I was carrying a diversity and inclusion rainbow flag, which is something I was very proud of. And as I said, I wore the silence equals death t-shirt, which is kind of made very famous by ACT UP and Outrage and all of those. But it did occur to me that perhaps I should be wearing a U=U t-shirt, because I think that's a very important message. But I didn't have one in my size. Susan, how could you help me on that?
Well, funny that you should say that, Matthew. And for those people who may not know what U=U is, it's undetectable equals untransmittable. Matthew?
Yes, I'm always telling people never use acronyms, and then.
But what's really exciting is that I've been working on behalf of NAM with the 4M network and wonderful Angelina Namiba. We've made a video showing how to make U=U t-shirts, and it is so much fun. Angelina is incredibly talented at sewing. I'm extraordinarily rubbish, but do check out the video on aidsmap's website and also 4M. I
would have to say the video is not only brilliant and instructive, but also hilarious, because Susan really is that incompetent.
At sewing.
But on the subject of U=U, let's bring on one of the world's leading U=U activists. It is Jacquelyne Alesi from Uganda. Hi, Jacquelyne, how are you?
Hi, I'm Matthew and Susan. Actually, about the U=U t-shirt, Angie made me one, sent me one. I wanted to put it on today, and then boom, it doesn't fit me. But I am happy I have it here, so I'm still holding it.
Show us the t-shirt.
Show us the t-shirt.
Show us the
t-shirt. Yeah, I have.
This is this very special episode of aidsmapCHAT where we show t-shirts to the camera. That's brilliant. Oh, that's beautiful.
So I think with the video that Angie did on how to make the U=U t-shirts, I'll be able to make one with my size. But thank you very much, Angie, and I really, really appreciate it. It's with me all the time. So
they are wonderful.
So yeah. Jacquelyne, you have a global role in U=U advocacy. I don't think we need to say what it means anymore, because I think everyone's got it from this episode. But I mean, are there like regional differences in the way the message is received?
Undetectable equals undetectable is the same, just that everywhere people say it in different languages. You'll find that some regions have defined it as I=I, K=K. It depends on how the different regions, the different languages that are used. But as regions, the message still says the same as U=U, but the definition of U=U changes as the way the countries actually, or the regions, pronounce U=U in their own language.
But do people do different regions? I mean, okay, I know that when I kind of talk about U=U on Twitter or whatever, like kind of some people, like the whole time. And you know, and you know, sometimes kind of people kind of go, oh, it's about sex, or other times it's about stigma, and you know, I mean, or some people are like, that can't be true. And I actually had someone from Ghana the other day say, oh, it's not the same where I live. Yeah. We don't have those medications, and I wasn't sure whether he thought that it was specific medications which made us undetectable, or whether it was something else. You know, so I was trying to unpick that with him. So, I mean, do you find those differences?
Obviously, I would say, because, you know, very many people would want to define U=U as they understand it. Some define it in terms of their treatment. Some define it in terms of their, you know, in their relationships. And some define it as something I would define as, you know, as the way they live in their countries. But one specific thing I can say about this is, when we talk about U=U, we are bringing in science. And this is something that very many people have to understand. We are talking about science. We are talking about reality. So in most cases, people think when we talk about U=U, it's something which is just there. It doesn't have any evidence. This is evidence we are talking about. You get my point. So in whichever way someone wants to define U equals U, as we've had experiences, it is science. It's based on science that we are explaining U equals U differently. But at the end of the journey, it is science that is trying to bring out the U equals U meaning. I don't know if that is how.
I mean, and that's one of the things I'm always saying is that, the science behind this is rigorous. This isn't just, we've got so many really strong studies which say, without any hesitation, without any doubt, undetectable means untransmittable.
Exactly. Yeah.
It's such a powerful message. But Jacquelyne, I know that you do lots of fantastic work with women living with HIV, and we so often face intersecting forms of stigma, discrimination, and disadvantage. But what are some of the steps you think should be taken now to address the health inequalities we face?
Can you just repeat it? Sorry, I missed that out.
Just in terms of, what do you think that we can do to sort of like stop the health inequalities? Like a couple of things that we can do to stop the health inequalities that women with HIV face.
One of the things is providing the services. One of the things we've seen, service inequality, there's been lack of delivery of services. We've seen the type of services that are provided to women living with HIV are sometimes very different from the services that women who are not living with HIV receive. We've seen a lot of discrimination, a lot of stigma that is happening when it comes to providing services, and this is already an inequality. Someone goes to deliver and then you ask them, why did you get pregnant? These are questions that I'll give an example in Uganda that are still being asked by health workers. We need to move away from questions that ask personal life, but rather to make sure that when we are providing a service, it should be equal to every woman, not just because of their status. If you are providing a service that is for a woman who their status, please provide the service justly, equally, so that this service doesn't limit them. We've seen where right now cancer screening, it's a must for women living with HIV. Can also this be a must to women who are HIV negative? These are things that we are talking about that really create about the inequality we are talking about. There are very many things that we need to really look at when we talk about providing the different services, the different information. We've seen this information that comes with where you're still being asked something that is not about you, but something about other people. So let the information be just, let the services be equal, so that we can really see a world where everything is equal and equality is served. That's briefly what I can say. Yeah.
Wonderful. Can't argue with that.
We're working towards it. And thank you so much for everything that you do, Jacquelyne. It's great to have you on the show.
Thank you, Jacquelyne.
Thank you very much. Yeah.
See you soon. Bye.
All right. Bye.
Bye. Oh my goodness, we've run out of time already. I would like to say a huge thank you to our three guests, Andy, Michael, and Jacquelyne.
And I'd like to thank our sponsors, Theratech and Wandsworth Oasis, and all the crew, Cameron and all the crew at Disruptive Media, who do all the tech stuff and make this look as effortless as it can be. We will be back. We will be back in 2 weeks' time. It will be our Pride special, so that's the 20th of June. And among our wonderful lineup of guests, we have the legendary HIV activist, Peter Staley. You may have seen him in the documentary or read about him in the book, How to Survive a Plague. He was one of the original ACT UP members, and he's an icon. So we're really excited to have him on our very special LGBTQ+ Pride edition.
So join us in 2 weeks' time at 6 o'clock live here again. So thank you all so much and see you in a couple of weeks.
See you then.
Bye.